few minutes left, so I'm just going to open it up to discussion. So if all of our panelists could join us. There's a reflection from Erica Johnson in the questions, and I think it really summarizes what comes up an awful lot. First of all, she says, thank you both to David and Kath for your experiences. But then she says, so considering the shortages of staffing and time actually allocated for clinician-patient conversations, I'm just wondering how the healthcare organisations and system can support these conversations. She's often told, I can only discuss one issue at an appointment at a time with my GP, and she contrasts that with a job as a physiotherapist, where she has much more time. So any thoughts around, in a highly pressured, this common thing, I don't have time. So I'd be interested. Jonathan, let's start with you. What you must hear this a lot from clinicians you're involved with and train, this whole thing. Yeah,
I do, Jim. I'm smiling as I heard you relay Erica's comment. The first thing I would say is that obviously acknowledge that we are in a high pressure situation. It is a busy service, and sometimes it is hard to think about ways to change practice when you feel very sort of rushed and busy. There was, however, a Cochrane review some years ago now, I can't quite remember exactly when, looking at shared decision making using decision support resources, and actually what it found was that if you did that optimally, then it added 1 extra minute to the consultation. So maybe it isn't quite as time pressured as people think it is. And secondly, there is also some evidence that actually often during a consultation, the clinician spends quite a bit of time actually talking to or at the patient rather than actually creating the space for the patient to actually speak to them. So maybe it's something about learning some of these new kind of communication techniques, and dare I say it, following Nikolai's presentation, having some of them played back at you on camera.
And Kath, from your point of view, from the other side of the table, I'm just wondering to what extent you feel sometimes you just feel talked at and there's more words being used which are actually needed. What are your thoughts?
Yeah, certainly does happen, especially with surgeons, particularly because they'll be quite focused on getting out what information to get your consent, because the decision's been made that surgery is going to happen, and also with GPs, sometimes with mental health. Because despite having this illness for over 30 years, I'm still not considered, in some GPs' eyes, as expert enough. So yeah, it does happen, and it certainly was distressing to find that in gynecological situations, because I was being spoken to by a male surgeon. By gender, I qualify as more qualified simply by knowing my own body better than he did.
And would you have any tips for people who find themselves in your situation, not being listened to, around how do you sort of make your voice heard? Because it requires a degree of assertiveness, doesn't it?
It does require a little bit of confidence, and I have to say, I think given the fact that I have a father who's a doctor is one of the reasons why I maybe have been emboldened and pushed to go and find a second opinion. But I feel like the complaints department at the hospital were brilliant and suggested that I had another surgeon, and even helped me find one that was more, had a better bedside manner maybe, but it was more into shared decision and understanding that this was my body and my operation, not his. But yeah, I would say it's difficult, but contacting, for instance, if you have a difficult situation with a GP, contact the surgery, find out who is the head doctor, see if you can arrange an appointment with them and express it, because no GP wants to actually give you a bad service deliberately.
Yeah, I think that's a really good point to end with. It can sometimes feel that everyone's to blame, but quite often a lot of this is actually just pure habit, really, and has come out of a dynamics of the many years of the way health services have been traditionally delivered. I think it's important to notice that this isn't anyone's fault, and this isn't a blame game. This is just quite simply how things have changed and how we've moved away from, how we used to be, particularly with the medical model of and some of its huge successes and everything which brought. And now, as we move into an era of long-term illness, predominantly, it requires a very different working relationship from the days where acute illness was so prevalent. Nikolai, there's a comment from Lisa Carr. I have unmuted attendees, so if Lisa's able to just put her comment to you directly, that'll be great.
Yes, so in terms of the great work that's going on in terms of recording, has any analysis been undertaken in terms of evaluating the impact in terms of reducing complaints and thereby litigation claims as well? Because again, I suppose coming from an angle of improvement in terms of service, the service also has an impact on the finances as well.
There has been, and actually they've published some quite interesting articles around the change in attitude from the point of view of the healthcare professionals, because there was a lot of fear implementing audio recordings. The funny thing is that, and this also relates to the question about time, that they actually experience that they have more time for the conversations, because, and one of the cool things is that they have found out a lot of these patients where audio recordings are really interesting is of course long-term conditions, and it seems that the quality of the follow-up questions from patients have increased immensely, which again increased the quality of the conversation at the next meeting and the next meeting. So first, looking at the quality, we've seen an amazing increase. Then regarding legislation, complaints and stuff like that, because they were quite interested in that as well. But it seems that most is solved through these follow-up questions. And this is what we've done, what they did at this hospital was that if you wanted to complain, it was there was a very clear pathway within the systems to do that. But we also had a questionnaire, so you sort of had to frame the complaint you had. And in this way also making sure that it came in the right setting, and of course there's been complaint, but no more than they saw before, and they have been more easy to sort of settle, because we have the audio recordings, and it's quite easy to have this discussion whether it was a good advice or not after the second advice, because you have the audio recording. So it's in some way it sort of reduced the amount of complaints and problems within the systems. And then again, the last point is that it also keeps the doctors on their toes if you know that you're audio recorded. So maybe they have been more motivated for doing training and conversation in actually using the tools for shared decision makings and so forth, because they knew that if they don't comply, they would get a complaint. So I think there's many mechanisms, and I'll try to email Jim the link to some of the public the references around the attitude from healthcare professionals and all these complaints, because they have published about this stuff. It is quite amazing. It's a very good story for everyone. Everyone is happy at the moment about being recorded, amazingly enough.
There's a really good comment from Jean Strauss. How do we, as patients, help ourselves out of blaming ourselves for received wisdom that we are either too female, too uneducated, too old, too large, too poor, too predictably ill, to actually feel confident to demand the best? And I think that's a very common thing we hear, or people actually, walking away blaming themselves for what's happened in a consultation, as it were.
This steams back into the power, who has the power in the communication. I mean, if you don't have the upper hand, it's more difficult to listen. It's more difficult to sort of commute the information you get, because you don't have the upper hand. So we need to create situations where you actually has the power to give questions back, and audio recording is one way of doing it. Another way of doing it is having two doctors in the room. That also has an amazing effect, because now you have two people working with the knowledge and trying to frame it down to what's actually important for the patient.
It's really difficult, and there's another comment here around patient or associations as well, to do more to equip patients so they know what questions to ask, because sometimes they just don't know what to ask and only later realize they might have taken a poor decision based on questions never asked and therefore information never shared. So there's a huge area here. We're going to pick some of this up in our webinar in January and subsequent ones. One is the skills to support healthcare professionals to have that conversation, that opening conversation around, tell me what you want to get out of this consultation. Tell me, so instead of asking what's the matter with you, what do you need, but actually asking people what's important to you right now. And those sorts of questions elicit a very different response from the person from the other side. If you ask, what's important to you? Well, it might be, well, it's important I stay in work. It's important I can get on with my life. It's important I stop worrying about this. It's important that, whatever it is, if we start from our starting point, the conversations between clinician and patient are very, very different. Rather than starting off with what's the matter with you, so why I'm in pain. But if we start off, what's important to you right now, what matters most to you, how can we support you, it opens up a very different conversation. And a lot of the tools and techniques are around that, and Jonathan mentioned things like talkback and that sort of thing to use in consultations, and also this whole area around decision support aids as well, to enable people to think through what questions they might want to ask. We're over time, but a huge thank you to all of our panelists, to Jonathan, excellent overview of shared decision making and its background, and that in itself raised a whole load of questions, to Kath and David, to sharing their experiences and the questions that raises around inbuilt bias, around how people are treated, and the assumptions which are made about us when people don't take the time to ask us. And thank you to Nikolai for a really challenging piece of work going on in Denmark around recording what actually goes on in the consultation room, so that because we know we hear what we want to hear, whether it's bad or good and all the rest of it, and having a recording is an incredibly powerful tool. So thank you to all of you. Please visit our websites for further resources, and please follow up with some of the panelists if you've got sort of further questions and interest. I know they're very, very happy to answer questions and hear from people as well.